Okay, today we can look at ocular biometrics. Uh, with other eye-related issues as we proceed in this series of presentations. So we will look at ocular biometric together with clinical correlates. We will look at some eyelashes disorders. We'll also look at some related myopic and hyperopia together with presbyopia. And then lastly, we'll say something small on color blindness. So as we start anatomically, this is the globe, that is the eye, and you can see the structures. We normally use this structure to illustrate a number of ocular issues. And you can see from this point, this is the cornea, and this is the anterior chamber. This is the lens, the pupil is here, the vitreous, the macula. So your light gets into from this side, all the way to the macula for you to be able to see. So one thing you need to know is that optical system of the eye is basically the media through which light passes through all the way to the macula. This is where we have high concentration of photoreceptors. The macula is just here on the retina. So the optical system must be transparent, for it to allow light to pass through. So for you to see, there must be light, and light must pass through all the way from environment through the eye up to the macula on the retina. The macula is right here. So all these structures, from the cornea, the anterior chamber which has the aqueous humor, the lens and the vitreous, we call it the optical system of the eye, or just the media. And it must be transparent for light to pass through, for you to be able to see. That tells you that any opacification in any of these optical or media structures, then it means you'll not be able to see. For example, if this lens becomes opacified, then you will not be able to see here. Or if you have any other opacification on the cornea as well, still light will not go through, and therefore you will not be able to see. So we normally use this structure for reference and explanation of some issues related to the eye. So what is ocular biometry? It is a measurement of the eye's anatomical structures, and it is mainly used in ophthalmology to plan surgeries, particularly cataract. Ocular biometry is also used in the diagnosis of eye conditions. So, what do we measure in ocular biometry? We measure the axial length, and this is the distance from the front of the cornea to the back, that is the retina of the eye. So when we talk of axial length, we are talking of length from this point here all the way to this point here. That is the axial length of the eye. What else do we measure? We measure the thickness of the cornea. And when we measure the thickness of the cornea, there are two readings. That is K1 and K2. This one represents the flat meridian of the cornea, while this one represents the steep meridian of the cornea. So this is what will determine the power of the lens of the cornea, the power in diopters. So these are one of the measurements that are done to evaluate the power. When we talk of power of optical system, we simply refer to how much can this media bend the light. For example, if I have two lenses here, this one here, and I have another one here, then this will be the concave, and this will be the convex. So when light goes through, light travels in a straight line. So this is our light. When light goes through a concave lens, it will be diverged. It will diverge like that. And when light goes into convex media, like that, this light will converge somewhere like this. So the concave lens will diverge the light, while the convex lens will actually converge the light. So the ability to converge this light, how much can you convert it? The ability of converging this light or diverging this light is what we refer to as the optical power. Optical power of that medium, and it's usually measured in diopters. So when we talk of shape and power of the cornea, we are simply talking of how much does this optical structure bend the light. Just to remind you, we have a number of optical structures of the eye, and we start with the cornea. Then we have, in the anterior chamber, we have the aqueous humor. It's also transparent with some minimal contribution to refraction of light. Then we have the lens, and then we have the vitreous humor. So all these structures you see here have characteristics. Number one, they must be transparent. Why? So as to allow light to go through. Number two, they have refraction. They can do refraction. Refraction is just bending of light. Remember, when light passes from one media to another, it bends. That is refraction. So the amount of bending this light is what we refer to as the optical power. optical power of that media, and it is usually measured in diopters. The total diopters of optical structures is around 60. There are always ranges. So you can proceed. So why is it important to do the ocular biometry? We do it, as we have mentioned, for planning during cataract surgery. So it will help you calculate the correct intraocular lens. Intraocular lens. Intraocular lens sometimes is abbreviated as IOL. IOL. So what does this one mean? If I may just take you back to this diagram here. In cataracts, there is opacification of lens. This structure here. Remember we said it is one of the optical structures of the eye. So it has to be transparent. But because of a number of issues, this lens can get opacified. One of the causes of opacification of this lens is age. Can be age. That is number one. Diabetes can also cause cataract. Another thing is something to do with steroids. So there are a number of issues that can cause this. A number of issues that can cause cataract. So cataract is opacification of this lens. So when we talk of intraocular lens, we mean that this is just an artificial lens. Artificial lens. Once this one has opacified, you do cataract surgery where the opacified lens is removed and then we fix the artificial one to restore vision. So that is intraocular lens. So we are saying that it is important to do biometry because it will help you to plan for the cataract surgery. It will even help you to calculate the power of the lens and refractive issues. You can use it to evaluate. Biometry measurements can also help us in issues to do with myopia, hyperopia, even diagnosis and monitoring. That is in cases of things like glaucoma, keratoconus, and axial myopia. Keratoconus here is just the cornea, which is appearing like a cone. For example, if this is our eye here, and this is supposed to be your cornea around here, and this is your eye with the upper eyelid and the lower eyelid. So if your lens, your cornea is supposed to be here, in some people, you find that the cornea is more protruding anteriorly like this. And that is what is known as keratoconus. So we shall see as we progress, particularly the issue to do with axial myopia and hyperopia. We shall see in the subsequent slides. There are two ways you can do ocular biometry. You can use an ultrasound biometry, which is known as the scan, and it uses the waves. It uses the waves just like an ultrasound. So it uses the waves to immersion technique useful when the lens is very opaque. When you can't see behind the lens, when you can't see the retina, then you can do an ultrasound known as the biometry to help you evaluate what is happening in the posterior segment of the eye. Then we have the optical biometry. This one uses light. So this one uses sound waves. This one uses light. Okay. What are some of the key ocular biometry measurements? We have talked of the axial length, and that is the distance from the cornea to the retina. And the normal distance is supposed to be 22 to 24.5 millimeters. So if this is the eye, with your cornea around here, then you are saying the distance from this point here to this point here is supposed to be 22. So range 22 to around 24.5 millimeters. So this is what we are referring to as the axial length. Axial length. Shall see the correlates. The correlate is that a long eyeball will give you myopia, while a short eyeball will give you hyperopia. So what does that mean in simple terms? It means that this axial length, the normal range is 22 to 24.5. So if you have a long axial length, let's say it is beyond 24.5 millimeters, then it means your eyeball is very big. Let me just, your eyeball is very big, and therefore, if this is your cornea here, remember light is supposed to get through, and you have your lens somewhere here. So light is supposed to get through and get focused at the macula. But because you have a long eyeball, the light will get through this lens. When it gets through, it will focus in front of the retina here. So instead of this light being focused on the macula here, it has focused here because the eyeball is very big with axial length more than 24.5. So what is the effect of this light focusing here instead of the retina? You will have this condition called myopia. And myopia is also known as short-sightedness. So these patients have a big eyeball with axial length more than 24.5 millimeters. When light gets into that eyeball, instead of focusing on the macula, on the back of the retina, it focuses in front of the retina, and therefore these people cannot see far clearly. Images that are far, they'll struggle to see. So they can only see things that are closer to them properly. So these people have myopia. That is the relevance of the axial length of an eyeball. And when you have a short eyeball, what happens? You realize that in this case, when the eye is small, like this, and this is your cornea here, let me just draw it a little bit better. Anyways, just for demonstration, it's not supposed to be very, very perfect. So your light will come from this side. Remember, light travels on a straight light. So this is your lens here. So light will get into this lens here. And when it gets into this, it will focus here. Instead of focusing on the retina at the macula, your light rays will focus behind the retina, because the eyeball is very small, meaning this axial length is less than 22 millimeters. So what happens is light will focus behind the retina instead of focusing on the retina. So these people are having this condition called hyperopia. Hyperopia means farsightedness, meaning these people, they have a problem. They cannot see objects that are near. They see objects that are far when compared to the objects that are near to the eyeball. So it is basically the opposite of myopia. It is opposite of myopia. So, as we had said initially, the cornea curvature is actually measured in two readings, that is K1 and K2, of which K1 actually represents the flat meridian, while K2 represents the steep meridian, steep and flat. So the cornea is usually divided into two, like this. So we have this plane that is going perpendicularly like this, and this plane that is going horizontally. So if you have, let's say, if your cornea is like this, and this plane, let me just show it this way, this plane towards vertical direction is, let's say maybe it is flat, then that's what we call a flat meridian. And it is represented by K1 when you do the measurements of the cornea. And for example, if this is our horizontal plane, it is now representing the horizontal meridian, assuming this horizontal meridian from this side towards this side is steep, then that is what is represented by K2. That is when you are looking at the readings of the cornea curvature. So another thing is the anterior chamber depth. Anterior chamber, for example, if you have the eye You will have to go back to our previous diagram of the eye to be able to explain what the anterior chamber means. Remember, this eye is usually divided in two segments. The first segment is known as the anterior segment. Another one is known as the posterior segment. So the anterior segment is the distance from this cornea here all the way to the lens, actually to the posterior capsule of the lens. So from this side to this side, back this side, is the anterior segment. Then the posterior segment starts from this side all the way to the retina. Now, apart from these two, this anterior segment is further divided into chambers. Anterior segment is again divided into two chambers, what we call the anterior chamber and the posterior chamber. So the anterior chamber is the space from the cornea here all the way to this point here, the iris here. This space here is the anterior chamber of the anterior segment. While this space between the iris here, the iris body, the ciliary body, all this space here, the iris all the way to the anterior aspect of the lens, is the posterior chamber. So remember, the eye is divided into two segments, the anterior segment and the posterior segment. And then the anterior segment is divided further into two, the anterior chamber and the posterior chamber. So when it comes to measurement of biometry, we are interested in the anterior chamber, this distance here. So you can go back to our slides and see what was being illustrated there. So the anterior chamber is the distance from the cornea endothelium to anterior lens surface. The normal range is 2.5 to 4.0 millimeters. So this anterior chamber is very important because it is normally used. It is usually assessed to diagnose things like glaucoma. So it is a very important aspect. It is important in glaucoma risk assessment and also intraocular lens positioning. Remember, IOL, we said, is just intraocular lens. So another important aspect measured in ocular biometry is the lens thickness. And the normal range is 3.5 to 5.0, and it increases with age. Another thing is the white to white distance. So when you have your cornea here, assuming this is the cornea, and this is the eye, so the distance, this cornea is usually transparent, and this other distance from here, we can say this is just the sclera, which is whitish. So when we met, this is also the sclera. This is also the sclera, which is also white in color. But remember the cornea, this one is the cornea, which is transparent. So when you measure from this point to this point, that is white to white distance. And the normal range is 11.0 to 12.5. It is used for sizing certain intraocular lens. At the center of the cornea, it is also another aspect that is normally measured. If this is your eye, if this is your eye, this is your eye, with the upper eyelid and the lower eyelid there. So, and this is your cornea around here. This one here. From here to here is your cornea. And this distance here, the cornea. So at the center of this cornea, we normally measure the thickness of this center, and the normal range is 500 to 550 micrometers. It is also important in evaluating glaucoma and also refractive surgery planning. So when you are measuring the intraocular pressure, IOP, the applanated tonometer is normally put here, normally pressed here, the tonometer. When you are checking the intraocular pressure, when you are measuring the intraocular pressure, the tool that is used to measure intraocular pressure is called tonometer. We call it applanated tonometry, applanated. It has been conjoined on the slit lamp. That's why it's known as applanated. So it normally uses some sort of pressure on the cornea here to be able to pick the pressure of the eye. Therefore, the center of this cornea here, its thickness plays a role. If it is very thin, then it means the tonometer will just press easily, and therefore it will give you, can give false positive. Means the pressures will be high, and remember the IOP, the normal range is 20 to around 21 millimeters of mercury. So if you have maybe say 22 millimeters of mercury of your eye pressure, but you have a thin cornea, the tonometer will just use very little force to compress it in the measurement process, and therefore it can give you maybe 20 millimeters of mercury, which is a false positive. False positive meaning you have no high BPs. The range is 10 to 21. You have 22, but because your cornea is thin, the tonometry faces very little resistance. Therefore, it reads your pressure as 20 millimeters of mercury. Say, this one indicating that it is within the normal range. It's a positive, but a false one. That's why we are saying false positive. The opposite is true. When the cornea center is thick, the resistance to our tonometer, will be much. Therefore, if you say, let's say you have 18 millimeters of mercury of intraocular pressure, but this center is thick, center of your cornea is thick, when a applanated tonometer is applied to measure the IOPs is just intraocular pressure. So when the applanated tonometer is applied here to measure your IOPs, because of the thickness of this cornea, it will exert resistance to this machine here, and therefore it can give you an exaggerated reading. Maybe, for example, it can give you 25 millimeters of mercury, just an example. But in real sense, the normal one, as per that case, is 18. But because of this thickness, it goes to 25. That's why we are saying the central corneal thickness is very important. when it comes to assessing intraocular pressure. And remember, glaucoma is normally caused by increased intraocular pressure, and therefore when you are assessing patients with glaucoma, you have to do tonometry to measure the pressure, and it's applied on the cornea, that machine. So this thickness plays a role. So when you have maybe say a thick cornea, it will offer much resistance to your tonometer, and therefore it will give you false readings. That is the importance. So it's important to know the thickness first of this cornea before you make some final decisions. Another issue measured is the size of the pupil, and these are the ranges. The normal range is 2 to 6 millimeters diameter, and it's usually important when it comes to refraction. So let's look at palpebral fissure. What is palpebral fissure? Let me take you to this diagram here. Palpebral fissure is the opening of the eyelids here. This space created when you open the upper eyelid. When you open the upper eyelid and lower eyelid. So the space between the upper eyelid and the lower eyelid, which exposes the eye, is what we refer to as the palpebral fissure. Palpebral fissure. So the normal palpebral fissure is normally measured, let me just go back to it again. It's normally measured horizontally, and also vertically. Horizontally is from this point here to this point, while vertically is from this point to this point. So, the normal horizontal measurement for palpebral fissure is also a range between 27 to 33 millimeters, while the vertical measurement is usually 8 to 12. So what is the clinical correlates? You'll have ptosis. Ptosis is just drooping. Ptosis is ptosis. Just drooping of the eyelid. And proptosis. This one is the protrusion of the eyeball. It is a common thing in what we call thyroid eye disease. In thyroid eye disease, patients will come with proptosis. How about enophthalmos? Enophthalmos is actually the opposite of proptosis, which means is the sinking. Is the sinking of the eyeball. Into the eye socket. This one for proptosis is protrusion of the eyeball, while the enophthalmos is actually the sinking of the eyeball into the socket. Entropion. What is entropion? Entropion in this case is basically infolding of the eyelid. So when you have your eyelid, for example, this is the eye. This is the upper eyelid, and this is the lower eyelid. So the upper eyelid and the lower eyelid. When an eyelid folds inside like this, if an eyelid folds inside like this, that is what we call entropion. So entropion is basically the infolding of the eyelids, while enophthalmos is the sinking of the eyeball into the eye socket. So the proptosis is the opposite of enophthalmos, because let me just write here. Proptosis, this is drooping of the eyelid, drooping of the eyelid. How about proptosis? This is protrusion, protrusion of the eyelid. How about enophthalmos? This is sinking. The eyeball sinks, sinking of the eyeball. Sorry, proptosis is protrusion of the eyeball, not eyelid. Eyeball. Eyeball. While enophthalmos is the sinking of the eyeball. Eyeball. Entropion is the infolding of the eyelid. So those are the meanings of those particular statements. This one we had already illustrated. So the process is this one here. You can see there's drooping of the eyelid. When the drooping of the eyelid occurs, we call it ptosis. And you can see the palpebral fissure is smaller compared to this one. This is the normal one. This is the abnormal one. So there's drooping of this eyelid here, what we call ptosis. Ptosis. And proptosis is this one here. You can see the eyeball of this gentleman here is protruding outside, and we said it's a common condition in what we call thyroid eye disease. Thyroid eye disease. Thyroid eye disease. That is proptosis. Enophthalmos, we said, is the sinking of the eyeball into the socket. And this is example here. When you look at this eye here, it has sunk into the socket compared to the normal one here. So that is enophthalmos. Entropion, we said, is the infolding of the eyelid, So when your eyelid falls inward, it's known as entropion. Now we want to look at something called hordeolum against chalazion. We want to look at hordeolum as well as chalazion. So, remember, hordeolum is also known as the style. Don't know if these pens are visible. Let me use a red one. Style. It's a very common condition. So, in medical terms, we call it hordeolum. Hordeolum. So, you can see there's a cyst here. This is a chalazion, which is just a swelling, and then we have a style here. So what is the difference between the two? What is the difference between hordeolum, which is the style, and chalazion? So we are saying hordeolum is also known as the style. So when we talk of a chalazion, this one is usually like blockage in medullary glands. So So this one is not an infection. But when it comes to a sty, this one is an infection, meaning it's a swelling that is caused by an infection. So that's the difference. A sty is caused by an infection, while a chalazion is just a cyst because of blockage of some mesodermal glands. So, this is further elaboration of the differences between a sty and a chalazion. So we are saying that for a hodioidium, which is a sty, it is most commonly found at near an eyelash follicle. So the bacteria enters this area through an eye follicle down there, and then it causes the sty. While the chalazion is most commonly found above the eyelashes and on the upper eyelid. So while the sty is commonly down here, the chalazion is commonly up there on the upper eyelid. While the sty is caused by bacterial infection, the chalazion is caused by blockage of an oil gland, which we call meibomian glands. While the odeolum, which is the sty, is tender and has swelling, the chalazion is usually firm and painless. So meaning this one is painful, this one is painless. In terms of treatment, while in a sty, we do spontaneous drainage. You can also do warm compression, and you give topical antibiotics. In a chalazion, we do warm compression. We also do steroid injection and surgical excision. So what is blepharitis? Blepharitis is inflammation of the eyelid. It's also important to differentiate between blepharitis and the sty. These pens are not very clear today. Let me just use this one. So we are saying blepharitis, and the sty. What are the differences? We said a sty developed as a single lump or nodule on an oil or sweat gland or an eyelash follicle. The blepharitis is the swelling of the entire eyelid. So here we have the swelling of the entire eyelid, while here the swelling is just a lump. We are saying blepharitis can be caused by bacteria and blocked oil glands. But a sty has a number of issues which can lead to the blockage that forms styes. So, it's important to know that with blepharitis, it is the entire eyelid that is inflamed, while with a sty, it is a single lump. It's important to mark the difference. Both of them are caused by bacterial infection on the surface, on the skin of the eyelid, but the blepharitis will include the swelling of the entire eyelid, while the sty is just a single nodule. So this diagram here illustrates blepharitis. You can see the entire lower eyelid is inflamed. So that is just an illustration. So we want to look at some eyelashes, some facts about eyelashes. The upper eyelid has about 90 to 150 eyelashes, while the lower eyelid is supposed to have 70 to 80 eyelashes. On one eye, that is the upper and lower, an individual is supposed to have around 150 to 250 eyelashes on one eye. And what is the length? The length of an eyelash. For the upper eyelid, the eyelash should be around 8 to 12 millimeters. While on the lower eyelid, the length of the eyelash is supposed to be 6 to 9 millimeters in that order. So the eyelashes are just these hairs on top of the eye. That is just a demonstration. So what are the clinical correlates of abnormalities of the eyelashes? There is something called trichiasis. And this is a condition where normal lashes grow inwards. Remember, if this is your eye, and this is the upper eyelid, while this is the lower eyelid, eyelashes grow on top of this eyelid here. So, for the upper eyelid, the eyelash is supposed to grow forward and upward. While for the lower eyelid, the eyelash is supposed to grow forward and downward. In the event where you have an eyelash growing forward and inward, or forward and inward like this, then this condition is what we call trichiasis. And what is the outcome of trichiasis? It will touch on the eye surface and it will irritate this eye surface, and it can even expose you to keratopathy, abnormalities of the cornea. And note, there's a difference between trichiasis and entropion. Trichiasis is the inward growing of the eyelashes, the hair, eyelashes. While entropion is the inward growing or infolding of the eyelid. The difference, eyelid. Eyelash is the hair, eyelid is the tissue. So when the eyelid grows inward, that is entropion. But when the eyelash grows inward, that is trichiasis. So it's important to mark those differences. And what is dystrichiasis? In dystrichiasis, it is a condition where eyelashes grow from an abnormal location on the eyelid, specifically from oil glands. So here, when there's an extra row of eyelash, we call it dystrichiasis. And then what is mandrosis? This is the loss of hair from the eyelids, eyebrows or eyelashes. This is a condition whereby individual loses the eyelids, the hair from the eyelids, as well as the eyebrows and the eyelashes. And what is scoliosis? This one is a condition which is characterized by localized patch of white or gray hair. So when you have white or gray eyelashes, the condition is known as scoliosis. So this is just a diagram to illustrate trichiasis. So this is the normal growth of the eyelashes. But when you look here, some are growing in a normal way, others are folding towards the eyeball. So when they fold towards the eyeball, the condition is known as trichiasis. This is a continuation of illustration of these eyelashes conditions. So this is the normal eyelash. This is how they grow. In distichiasis, there is abnormal layer here. And then in ectopic cilia, there is another ectopic eyelash outside the normal rows. And then tracheasis, there is the infolding of those eyelashes. So these are the measurements of the cornea we had already mentioned. The central thickness is about 520 to 550 micrometers. And then as you move on the periphery, so if I may draw again the eye here, and this is just the upper eyelid, and this is the lower eyelid, and this is your cornea here. From here to here is your cornea. So the central measurement is what we are calling or saying is supposed to be 520 to 550 micrometers. But as you move towards the periphery, from the center towards the periphery, then the length is a range of between 600 to 700 micrometers. Okay, and the normal refractive index of the cornea is 1.375. Remember, refraction is just the bending of light. When you study optics, you will find characteristics of light. And characteristics of light: one, light travels in a straight line. Two, light can bend, what we call refraction. And then three, light can also bend backwards, what we call reflection. Among other characteristics, this is covered in optics. So when the light bends, what we are calling refraction, which is the bending of light. Bending of light is actually measured when you compare the media with air. We normally call it a refractive index. And for the cornea, refractive index is 3.75. When light is moving from one media to another, it will bend. It bends. And remember, our optical system, one of it is the cornea, which is a different media from air. So when light is moving from air, which is a different media, towards the cornea, which is another media, the measurement of that bending of light, the ratio is normally referred to as the refractive index, and the refractive index of the cornea with respect to air is 1.375. The refractive power, the ability to bend that light, for the cornea, anterior surface, we have 48 diopters. Remember the cornea, if I may redraw again here, it's a lot of drawing. So this is the cornea. We have the anterior, the posterior surface, posterior surface, and this side is the anterior surface. So you can see, if you do like this here, this one becomes the posterior surface, while this side becomes the anterior surface. So the anterior surface of the cornea, its power, refractive power, is 48 diopters. Remember, refractive power, we said, is the ability, the power to bend light. How much do you bend that light? It's measured in diopters. We call it refractive power. So the anterior aspect of the cornea has a refractive power of 8 diopters, while the posterior surface has about -5 diopters. So the total cornea power, you just add 48 diopters plus -5 diopters, and you'll get that is about 43 diopters. So the total refractive power of the cornea is about 43 diopters. And you need to know that the cornea contributes about 70% of the eye's total refractive power. Remember we said the optical system, we can remind ourselves again, the optical system, structures of the eye, we have the cornea, we have the aqueous humor, which is in the anterior chamber. We have the lens, we have the vitreous humor. And we say all these structures have similar characteristics. They have transparency, they have to be transparent. They also have optical power, which means they bend light. They have the ability to bend light. So of these structures, the cornea is the one that has the highest power. You can see it contributes the total refractive power of the eye is about 60 diopters. So out of the 60 diopters, the cornea contributes about 43 diopters. So you can see, that's why we are saying the cornea here, this one represents about 70% of the total refractive power of the eye. So you can see it's a very important structure. Of all the optical system or the media, it contributes 43 diopters out of 60. So that's why we're saying the cornea contributes about 70% of the eye's total refractive power. So that's just a human eye. There's not much to talk about. These are repetition of the measurements, some of the measurements that we have been talking about. The sclera, the cornea. The limbus is just the junction between the sclera and the cornea. Remember, when you have your eye here, and your cornea is from this point here, the cornea, we said, is supposed to be transparent. This other space here, from this point here, is the sclera. The same thing here. This is sclera. So what we are saying is that the junction between the sclera here and the cornea here, this is the cornea. This junction here and here is what we call the limbus. The limbus. So those are just an illustration of some of the things that we have already talked about. It is a continuation in this slide again. But here now, there are other issues that have been added on. The axial length, which is also known as the anterior posterior diameter, we have already talked about it. It's about 24 millimeters. Then we have the horizontal diameter. Now there is a vertical. When you have the eyeball like this, let me use this. From this point to this point, this is what we call the anterior to posterior. Anterior posterior. From the center of the cornea to the center of the eyeball at the back there. That is the anterior posterior diameter, it is 24 millimeters. Then we have the horizontal diameter, this one here. It's about 23 millimeters. Then the entire circumference of this eye, circumference, is about 75 millimeters. And then the total volume of the eye, the volume of the eye is about 6.5 millimeter cubed. And then the weight of the eye, the weight is about 7 grams. Then the total refractive power of the eye is about 60 diopters. Those are just some facts about the eye. So the clinical relevance of a small eye and a big eye we had already illustrated in terms of convergence of light rays as they get into the eye. So when you have a short eyeball, you get hypermetropia, and hypermetropia we say is just farsightedness. These are people who can see far clearly, and when the object is moved near, they find it difficult to see it clearly. And myopia, we say this is short-sightedness. These are people who can see objects that are near clearly compared to objects that are farther away. We had mentioned about it, and this is the illustration. This is the illustrations. So in myopia, the eyeball is very big, meaning the anterior posterior diameter is long. It's beyond 24 millimeters, beyond this pens. Beyond, it's over 24 millimeters. So when light gets in the eye, instead of focusing on the retina, it focuses in front of the retina here. So it becomes difficult. You know, light is supposed to be focused on the retina and the macula for you to have a sharp focus of the object and see it clearly. But when light focuses in front of the retina, because of a large eyeball, then you become myopic. You can't see objects that are far away clearly. And this condition is usually corrected by concave glasses, concave spectacles. When we talk of concave, it has this shape. Remember, concave glasses, they normally diverge. They divide light. So these are the light rays. So when the light rays get into a concave mirror, so you normally wear a glass here, the spectacles, which are now concave. So they will diverge this light. When they diverge it, it will push it further to the retina now. There. Because it diverges light. Since our light is supposed to reach the retina, but it is reaching somewhere here, then you need this lens, these glasses, which can diverge the light rays and push it onto the retina. So myopic patients are normally corrected using concave glasses. And hypermetropia, we said, is farsightedness. And here we say you have a small eyeball, which means the distance between the anterior to posterior aspect is less than 22 millimeters. Therefore, instead of light focusing on the retina, it focuses behind the retina somewhere there. So when it does that way, these patients can see far clearly but not able to see objects that are close to them. So these ones are normally corrected using the convex. Convex looks like this. Convex. Convex, when light gets into it like this light is usually bent and it focuses here. It focuses here. So instead of light bending backward, when we put a convex lens here, it will bend this light closer to the retina. And then it will correct that error. We call it refractive errors. So this one is corrected by concave, while this one is corrected by convex glasses. And what is presbyopia? Presbyopia is also a refractive error, but this one is age related. It has nothing to do with the size of the eyeball. You can see, it is a common age-related vision condition where your eyes gradually lose the ability to focus on near objects. So, when you have your eye here, and this is the cornea, and this is the lens, and this is the suspensory ligaments. These ones we call them suspensory ligaments. And this is your lens. And this is your cornea. And this is the lids. The upper eyelid and the lower eyelid. So light comes into this eye like that, and this lens, you have something called the ciliary body somewhere here, the ciliary muscles. They contract and relax to adjust the shape of this lens, which means this lens is supposed to be elastic. When you move an object near to the eye, the muscles, the ciliary muscles here, we call the ciliary body, is supposed to contract, and when it contracts, it adjusts the size of this lens, the shape actually. So you'll find that it is, when the object is very close to the eye, they will relax and they'll make this lens to be more convex like this. And when the object is very far, these muscles also adjust this lens and make it slightly convex like that. So you can see the difference. That is how the lens work, to adjust the lens, the size and the shape in terms of the distance of the object, if the object is here. So when you move an object closer to the eye, these muscles are supposed to relax and bend this lens so that this lens become more convex, so that it can now bend. The reason for this is to bend this light accurately to the macula for you to be able to see clearly that object. And all this process is known as accommodation. So it will involve one, changing the shape, changing the shape, changing the shape of the lens. Number two, changing the size, changing the size of the pupil. Then number three, you have convergence of the eyes. These are the components of accommodation. So what it means is that when an object moves closer, the lens shape is supposed to change. At the same time, your pupil, the size will become smaller. And then number three, the eyes are supposed to converge. When we talk of convergence of the eyes, it means these eyes have to move to align themselves inwards, all of them, as they focus on that single object. For example, if I'm focusing on this pen, then this eye and this eye are supposed to converge, and all of them are supposed to focus on this eye. So those are the three components of accommodation. So what happens in presbyopia, these patients, because of age, this lens lose elasticity. And that's what we're saying. Inside your eye is the lens, and this is the lens. This is the lens. This one here. And their work is to change the shape so as to focus on an object. But with age, this lens becomes stiffer, meaning they lose their elasticity. They lose their elasticity. Meaning they will not be able to bend and focus on the object. So this is related to the concept of accommodation, as we have explained. So in this case, these patients have a problem in seeing objects that are near. That's why you'll find that this patient will want to move, if it's a book, he'll want to move it further like this for them to see. Because when you move them closer here, the lens have lost elasticity because of age, and therefore they cannot change the shape and bring that object into focus in the process we refer to as accommodation. And this problem starts in patients with about 40 years, 45 years onwards. That is when this problem starts setting in. So we are saying presbyopia is a refractive error that is age-related. It is caused by stiffness of the lens. The lens have lost elasticity as you grow, and therefore it cannot undergo accommodation to focus on near objects. Therefore, you find these people, for them to read a book, they have to move that book further or strain the eyes to see. These are the symptoms. Number one, they have difficulty in reading small print. Number two, holding books or phones far away for them to be able to read, because when you move closer they can't see. Number three, they normally have eye strain or sometimes just headaches when doing close work. And number four, they experience blurred vision. When you bring the object near to them, they will have blurred near vision. But when you move this object far, they'll just be able to read it. So how do you correct this error? In presbyopia, they normally get glasses, reading glasses. But remember, presbyopia is not a disease. It is age-related. It is age-related. Therefore, you can just try to manage it, but you cannot cure it completely. Because remember, The lens have lost elasticity, and the reason is because of age. So the lens fibers become stiff, such that they cannot accommodate. They lose accommodation. And we say the accommodation in simple terms include bending or changing the shape of the lens in relation to the distance of the object. So it is normally corrected by using reading glasses, which are mostly prescribed, and they can be bifocal or progressive lens. They can also use contact lens that are attached on the cornea, or even surgical options. So let's talk about the pupillary distance. Pupillary distance is just the distance between one eye to another. Remember, human being, if this is your head and you have one eye here and one eye here, this distance here, from this point to this point, is what we call pupillary distance. So the pupillary distance for male is 54 to 68 millimeters. The pupillary distance for female is 54 to 62 millimeters, while the pupillary distance in children is 43 to 58. So that is the distance we are just talking about. That is an illustration to indicate for you what we are talking about. And the pupil, the normal diameter of the pupil in bright light is 2 to 4 millimeters, while in dim light is about 4 to 8 millimeters. So what you need to know is that the pupil changes in size, and in bright light, the pupil reduces in size, while in dim light, what we call the photopic condition, the pupil increases in size so as to allow light to get into the eye. What are the clinical correlates of these issues? There is an issue known as isochoria. In this case, both pupils are normal in diameter. But when you have one pupil is smaller than the other, then the condition is known as anisocoria. While when you have a pupil that is white in color, then the condition is called leukocoria. Actually, when you look through the pupil, you are supposed to see something like red-orange. This is what we call the reflex. This is the retinal reflex, retina, from the retina. So if you have a opacification of the lens, you will not be able to see this. You will just see something like white. For example, if you have opacification in a condition called cataract, then you can have your pupil appearing white, which is not normal, it's diagnostic. And then mydriasis is the dilation of the high pupils, while the miosis is constriction of the pupil. This is just the sizes of the pupil in different light. In dim light, you can see the pupil is very big. In normal light, it's normal. And in bright, it is small to reduce the amount of light that's entering the eye. It's the same thing, continuation of what we have already talked about. The same thing, the normal versus anisocoria. Remember, we said anisocoria is a case whereby the pupils, one pupil is normal, while the other one is not normal. This is the normal red reflex we are talking about. When we look through the pupil in ocular examination, supposed to see a red reflex. But in the event you see a white reflex, then it means that is leukocoria and it's diagnostic. It means there's a number of things you need to check from that patient. And that is leukocoria that we have talked about. This is the average depth of anterior chamber we had also talked about. The normal is 2.5 to 3.5 millimeters. The average volume of the anterior chamber is about 260 microliters. In clinical relevance, any depth that is below 2.5, we call it a shallow chamber, and therefore this patient has increased risk of increased IOPs, which is intraocular pressure, as well as glaucoma. And that is what we also refer to as ocular hypertension. These are further eye-related terminologies and pathologies. When you have pus in the anterior chamber of the eye, it's known as hypochlon, and these are the causes. When you have blood in the anterior chamber, it's called hypema, and these are also the causes, possible causes. So I want us to look at color blindness. And you are saying color blindness is usually a condition where individuals have altered ability to see or distinguish between certain colors. And these colors normally are the primary colors. Primary colors. Here we are talking about green. We are talking about blue. We are talking about red. They are primary colors because all other colors originate here. So, in the eye, we have photoreceptors of two types. We have the rods and we have the cones. The rods are sensitive to dim light, while the cones are sensitive to bright light. So we are interested in the cones for now because they are the only that are responsible for color vision. And these cones are of three types. We have those that are sensitive to red light. We have those that are sensitive to green. And we have those that are sensitive to blue. In the event that you have cones that have defects for red color, then it means you'll not be able to visualize red color. And this issue of color blindness is recessive, X-linked, inherited condition. It means the genes that determine color vision, are linked to the X chromosome. Let me just grab this so that we can talk about this issue in details. So I take you back to the chromosomes. We have two classes of chromosomes. We have autosomal chromosomes, and we have X chromosomes, So for X chromosome, it's just one pair. And for autosomal chromosome, it's just 22 pairs. So 22 pairs plus one pair, human being is supposed to have 23 pairs. 23 pairs of chromosomes. has two. So in simple issues, then we are saying human beings have a total of 6 chromosomes. So autosomal chromosome, this one here, will determine characteristics of a human being, while the X chromosome, this one here, they determine the sex of the baby. And this is where we are. The sex chromosomes are 2. XY for boy and XX for female. So we are saying